All right, here we go. We're going to talk about fluids, electrolytes, diuretics, and a little surprise at the end. Shouldn't be too bad. I think I guessed correctly at the course number. Is it 342? I think so. Let's start with fluids and electrolytes, and I'll just give you a brief review from Patho. And first, a little vocab word. We're going to use the term third space periodically. You're going to hear it all the time when you're practicing. And don't get confused by it. You know, there's the cellular space. You know, there's the intravascular space. And then there's this third space. We also call it the extracellular fluid or the interstitial space. It's got 1,000 names, but that's essentially what the third space is. It's not intracellular and it's not vascular, so it's somewhere else. The third space. So the electrolytes, you remember, are either negatively charged ions or positively charged ions. We call the positively charged ones cations. That should be cations, though, don't you think? It looks like cations. Anyway, and negatively charged are anions. So the major anions are chloride, bicarb, and phosphate. And the major cations, the major one is sodium. We see more sodium than we do of anything else. We worry more about the potassium than we do anything else. But also magnesium, calcium, hydrogen are others that we have to be concerned with. So the whole idea is that when the cations and the anions are about equal, whether it's intracellular or extracellular space, then you're at homeostasis. Now, when there's a difference in that concentration, then we have to talk about how the fluid moves. And remember, it's the fluid that moves, not the solute, right? Not the things that are dissolved. To start with, you should know that this is a hugely powerful mechanism. The concentration of ions in fluid is very, very powerful. So much so that if you take a eosmotic cell, right, just a normal cell that has the right concentration of potassium and sodium and calcium and all that stuff inside of it, glucose, take that and plop it into pure water, something that doesn't have electrolytes or anything, then that membrane would be exposed to 5,400 millimeters of mercury. That's the same thing that we measure blood pressure in, millimeters of mercury, right? So imagine a pressure of 5,400 millimeters of mercury. It's insane to think about. That's a huge amount of power that happens just from concentrating some solute inside of a solution. Okay? So remember that we have isotonic when there's just the same amount of solute outside as there is inside the cell. When we have a hypotonic solution, that means that there is less of the solute in the fluid, and that means that the fluid is going to go into the eukaryotic cell or the eosmotic cell and try to dilute that hyperconcentrated, seemingly hyperconcentrated intracellular fluid. All right. And that makes the cells get really big and swollen. And then there's hypertonic fluid where there's more solute in the fluid and less inside the cell. So what happens here is that the cell donates fluid to the outside world, the extracellular fluid, trying to dilute the extracellular fluid and bring it to homeostasis. Okay? So this pressure that we have, this concentration of ions in the cells and in the blood, and when we compare them side by side, it has a huge implication for how water moves in the body. So this osmotic pressure is very important. So too are the pressures that move fluid in and out of the bloodstream. So let's just think about osmotic pressure, which we just talked about before, is the number of particles in solution and the degree of ionization, right? The number of particles that are in solution, whether we're talking about in the cell or in the extracellular space or in the bloodstream, whatever we're talking about, that's osmotic pressure. It's the pressure that is exerted by the concentration of stuff. We'll say ions here. Now, the way we calculate that osmolality is it's 2 times the sodium plus a little bit of the BUN plus a little bit of the glucose plus a little bit of alcohol if it's in there. And I say a little bit because we take each of those factors and we, or addends, I'm sorry, not factors, and we divide them, right? So it's a little bit, the BUN divided by 2.8 is just a tiny bit of BUN. So the overwhelming majority of this equation is 2 times the sodium. So the sodium is what we can use as a quick way to eye what the osmotic pressure is. Just look at the sodium. That gives us a really good idea right off the bat. The way that we use this, the clinical benefit when you're a nurse taking care of these patients, is that osmotic pressure is the force that moves water in and out of the cell. Okay? Just think of it that way. Let's keep it simple. It's the force that moves water in and out of the cell. Remember, it's not the particles that move. That requires energy. We're talking about osmosis and diffusion, and that's what osmolality, the osmotic pressure, allows. Okay, so let's set that aside now, and let's talk about how the Starling effects work. So essentially, there are forces that work on pushing fluids and particles out of the circulation and pulling fluids and particles, like glucose, for instance, inside the circulation, okay, from the extracellular space or the interstitial space, or the third space as we call it. So the hydrostatic pressure is the easiest to understand. It's just the blood pressure. And by the time we get down to the capillary level, the arterial end of the capillary has a blood pressure of around 25 or so. So it's very low, but that's significant because when we subtract out the colloid osmotic pressure, or what we call the oncotic pressure, that leaves a slight force that's pushing fluids out. Okay, it's about 5 millimeters of mercury. Now, for our purposes, we're just going to think about those 2 things. The hydrostatic pressure, which forces things out, right? Forces fluid out at the capillary. And notice at the arterial end of the capillary, it's pushing out and has a higher force. But as we move toward the venous side, we've gotten rid of most of the fluid that we're going to get rid of. And now the oncotic forces are pulling fluids in. And so this becomes a point where there is equilibrium. Okay, so now let's talk about the oncotic pressure, which is shown here in the blue. The oncotic pressure starts out very low here and gets higher as more fluid leaves the bloodstream here in the capillary. And now it's more concentrated with protein, because that's what it is. The clinical utility is that the oncotic pressure is the force that holds fluids in the vascular space, and it's due to these giant molecules like proteins in particular. And the number one protein that we're going to think about is albumin, right? So as we get rid of fluid from the hydrostatic forces, now the oncotic forces are trying to push fluid back in, right? The oncotic forces from the higher concentration of protein at the venous end are going to start pulling in water, and now we get equilibrium. Okay? So this is a very complicated, it's not that complicated, but it's more complicated than I care to talk about. And so we're just going to use the albumin level as our guide for knowing what the oncotic pressure is. If the albumin level is too low, and it very often is in older adults, then we're going to see a little bit more edema, right? We're not going to have a big force. If the protein levels in the blood are low, it's not going to be pulling in as much fluid from the interstitial space, and therefore we're going to have edema. Okay? So listen to that again if you need to, and ask me if you still don't understand after you've tried to understand it. Let me know. I'm happy to help you. By the way, ions, if you didn't remember this, ions are just charged particles, right? So K plus, magnesium 2 plus, those are charged particles. They don't have a dancing partner. So until they get a dancing partner, they're still going to be all charged. When they get a dancing partner like potassium chloride or mag oxide or magnesium sulfide or whatever we're talking about, that's when it balances, right? That's when the positive or negative sign disappears. So remember that the ions are the active ones. They don't have a dance partner, so they're still available. They can do mischief. Okay? All right, so volume status is on a continuum, right? Euvolemia, darn it. Euvolemia is the homeostatic part. That's where we have just the right amount. It's Goldilocks, right? Not too little, not too much. It's just right. Then we have hypovolemia. And when patients are hypovolemic, that can lead to things like hypotension, dizziness, syncope, and in particular, the kind of hypotension that we see in older adults, particularly if they have something like Parkinson's disease. We often see that orthostatic hypotension. And then if they're hypervolemic, they come in, think of heart failure or end-stage renal disease, and they're not on dialysis yet. They come in, they have a huge amount of edema or third spacing, right, where this fluid just leaks out. So let's talk about how we manage these fluids and electrolytes, and we'll start with identifying the two types of IV solutions that we have. They are colloids and crystalloids. So crystalloids are traditional IV fluids. So it's water and electrolytes. And you can think of things that affect, or that are examples. Normal saline solution, lactated ringers, D5W, D5 half normal saline, all those. Colloids are solutions that are made up mostly of proteins. So think about milk, for instance, right? Has lots and lots of protein in it. It's good for you. Of course, we don't inject that into our veins, so we have other ways of getting that protein. But this colloid solution is what increases oncotic pressure to draw in fluid from the interstitial space. When we give crystalloid solutions, some of it's going to leak out into the interstitial space, but we'll take it. So crystalloids are fluids and electrolytes found naturally in the body. There's no proteins in this, and they are distributed very quickly between the interstitial and intracellular compartments. So they're really good at fixing dehydration. You have too much dehydration, we give this stuff, it repletes the amount of water in the cells, and everybody lives happily ever after. But we may get edema if we give it too fast, or if we give a long, maintenance IV fluids over a long period of time. It can worsen acidosis. It has short-lived effects because when you give a liter of normal saline or lactated ringers, for instance, only a quarter of that stays in the intravascular space. The rest of it leaks out. So we have to be very cautious about this, about using crystalloids. They also dilute the plasma proteins. And what happens if the plasma proteins like albumin are really low or diluted? Well, then we have low oncotic pressure. And what happens when we have low oncotic pressure? Fluid leaks out of the intravascular space and goes into the the interstitial space or the third space. Okay? Common crystalloids, saline, dextrose. Those are the two big ones that we see. So isotonic, saline is an isotonic solution. That means the oncotic pressure of the solution is about the same as what your bloodstream is. What's it mean when it's 0.9% normal saline solution? Well, it has to do with the number of grams per 100 milliliters of fluid. And so 0.9% normal saline solution has 9 grams of sodium chloride per liter. All right. Dextrose, which we see in D5 quarter, 2.5% dextrose in water, D5W, which is 5% dextrose in water, D10, D20, and D50. These are all different percentages of glucose that are dissolved in solution. Now, just like we talked about with the sodium, each percentage that you see there represents 1 gram of dextrose per 100 milliliters of fluid. So if we have 1,000 milliliters or 1 liter, we're going to have 5 grams of dextrose per 100 mils of water, or 50 grams per liter. And by the way, that gives you 200 calories, doesn't it? Remember that carbohydrates have 4 kilocalories per gram. So you're going to get 200 calories out of a liter of D5W. Okay? You should be able to do some of those calculations too. Free water is just a word that we use that means that we don't have electrolytes dissolved in it, right? Tap water and D5W are the most common examples. So we give tap water when we want to give, say, tube feeds. And we find that they become hypernatremic, right? We give tube feeds, their sodium level goes up because they don't have enough free water. We add free water, which is tap water that we use to flush the tube, or we mix it with the tube feed or whatever. All right. When we give it IV, of course, we never give tap water IV, right? That would be stupid. But when we need to give free water to rehydrate somebody IV, then we give D5W usually. So tonicity, remember, has to do with the concentration of solute in the solution. So we talked about isotonic. Iso means it's just right. It's the Goldilocks, right? So normal saline and lactated ringers are the two isotonic solutions that we usually refer to and that we most frequently use. Hypotonic is something like half normal saline or D5W, where there's just not enough solute in the solution to make it have a normal osmotic pressure of, what's normal, like, I don't even know, 270 or something like that, 275. And then hypertonic is where we give too much on purpose. We give extra solute, like in 3% saline, instead of 0.9%, with the 9 grams per liter, we're going to give 3%, and that's going to have a whole lot more tonicity. It's going to draw in water from the intracellular space, right? Okay. Here's a little summary. You can download this. It's a full PDF, I believe. Or at least a picture, and you can carry it with you. All right, so that's crystalloids. That's the easy stuff. That's the stuff that it looks like water. You get it in an IV bag and you hang it. You just have to make sure you get the right stuff. Now we're going to talk about colloids. Now, remember, these increase the oncotic pressure. And what that does is it moves fluids from the extracellular or extravascular space, also known as the interstitial space or the third space. There's a million names for it, right? All the same thing. And that moves that fluid into the blood vessels and therefore achieves homeostasis. So we can use this to expand blood volume. somebody's really, really hypotensive and they don't have enough extra fluid. They have a ton of edema, but they don't have a lot of extra fluid in the in the intravascular space. Then we sometimes give a colloid like albumin, and that increases the oncotic pressure, pulls in more fluid from the extracellular space into the vascular space, and then it increases the pressure so that we can pull in even more volume. Okay. So we can do this with albumin, proteins like albumin. We can use carbohydrates like dextran. We could use fats to do this, or animal collagen, but I'll show you the most common ones that we use. And really, I don't care that you know anything about the other three here, but know the albumin, all right? Excuse me. Albumin 5% is it's 250 cc's, comes in a glass bottle. It's from pooled human donors who were giving blood or their plasma or whatever, and they just extract the albumin from it, put it in a bottle, and sell it for $1 million. Really expensive. It has a rapid onset of action, so it works very well to increase the blood pressure and pull fluids in from the extracellular space. But it also is very quickly metabolized. So think about who has all this edema and everything. They're usually very sick patients, and they're probably malnourished, which is why their protein levels are low. So when we give the albumin, the body actually likes it because now I get to eat, right? It uses that as an energy source. But while it's in the vascular space, it increases the colloid osmotic pressure. Okay? We don't like to use it, and these are relative contraindications. We don't use it when there's volume overload in the vascular space. So like heart failure or end-stage renal disease. But I did just say earlier that we use it in heart failure, didn't I? Well, this is where we have tons of edema, but blood pressure's low and they don't have enough intravascular volume. I know it's confusing. So we say that it's contraindicated in heart failure, but sometimes we need it in heart failure. Depends on where the patient is. The one time we never use it is if there's severe anemia. And this should make sense to you. If you think I have diluted apple juice, like your mom used to give you when you were a kid, and now you're going to dilute it even more before you give it to the patient's going to end up not drinking it. It's going to taste like water. How disgusting, right? Well, the same thing is true with using volume expanders like albumin in severe anemia. We already have very diluted blood. There's not enough oxygen carrying capacity because there's not enough red blood cells. Now we're going to dilute it more with giving the albumin, and then it's going to pull in more fluid from the extravascular space. Now we're hosed. Now we have really low or really severe anemia with a much lower blood count. So in this case, the colloid that we would use if they're severely anemic is probably blood. So in clinical practice, we consider blood products to be colloids. It's the only, this is very important, it's the only class of IV fluids that carries oxygen. And you already knew that because we talked about it last semester, and you guys, you were able to tell me that without me even teaching it. So we use blood when we want to increase oxygenation and increase plasma volume. Realize that it is the most expensive and the least available because we need human donors for it. We don't yet have an artificial blood substitute. They're working on it. They've been working on it for 30 years or more. We still don't have it. Now, there's other kinds of blood products that are also high in protein, cryoprecipitate and plasma protein factors, or PPF. We use those for managing different kinds of hemophilia and things like that. Bleeding for specific reasons. Then we have fresh frozen plasma, which increases the clotting factors. And again, those are made by the liver, and they become a integral part of the protein store or protein content of the blood. We can give packed red blood cells. That's the most common way to give blood. But if you're in a trauma unit, we give whole blood, or we give packed cells, a couple of times. Then we give them platelets and FFP and stuff. But whole blood does not separate out the red cells from the cryo, from the protein plasma factors, from the clotting factors in FFP. It's just administered as whole blood. And that's a trauma thing pretty much exclusively, because we can give all that other stuff in smaller doses if we need to. So what are the the adverse effects or the problems with blood products? Well, of course, adverse or incompatibility with the recipient's immune system. So if you're A positive and you get, well, let's put it the other way around. If you're O negative and you get A positive blood, that's going to be a problem, isn't it? Or if you're B and you get AB blood, that's going to be a problem. So that we have to do cross-match testing. We have to monitor always for transfusion reaction. And what is the first thing that happens with transfusion reaction? The most worrisome sign? Fever, right? So we check for fever and the other vital signs, hypotension and all those other things, tachycardia, but usually associated with a fever. So we check for that constantly while we're giving blood. Anaphylaxis can be a problem. And of course, we can always transmit hepatitis or HIV. Now, the blood supply is tested for those, but it's possible, theoretically possible, that it could still be spread because there aren't yet antibodies, even though the antigen, the hepatitis virus or the HIV virus, is there, but it hasn't yet caused the body to generate antibodies yet. All right, let's talk about electrolytes. So I got this from a medical physiology textbook. I love it. So this is the extracellular fluid. This is the intracellular fluid. Notice what's mostly intracellular: phosphate and some other organic anions, protein, mostly concentrated inside the cell. Potassium is almost all inside the cell. And look at this. Sodium is almost all outside the cell. And look how much of it is almost all outside the cell. Like 135 to 145 milliequivalents per liter. Look how much potassium is inside the cell. Like 145, 140 milliequivalents per liter. See, these are exact opposite, aren't they? So the sodium level in the bloodstream is pretty high. That's the extracellular, but intracellularly it's very low. Extracellular in the bloodstream, the potassium level is very low. So this exchange through the sodium-potassium pump is what causes the part of the action potential, right? And you learned about that in A&P. I know you did. But I just think that that's an important thing to understand. These two things switch places when there's an action potential. Okay. Most of the chloride is in the bloodstream circulating, and it's in the neighborhood of, 98 to 110 or whatever it is. Most of the bicarb is circulating in the bloodstream, etc. So this is just a nice thing to sort of keep in your mind when you're trying to understand where all these things exist in the body. Let's start with hypernatremia. If you see a red check mark like this one, that's one I want you to really know. I want you to understand and know this slide. All right. So hypernatremia is where the sodium is more than 145. It's high because the water level is low, right? When you don't have enough water, if you drain out the water from the bloodstream and leave the solutes in there, the potassium or the sodium level now is going to get higher, isn't it? So we need to give back water to sort of dilute that sodium level. Diabetes insipidus, hyperglycemia, which makes you pee more, febrile illnesses, all these other things. If you drink too much seawater, so drownings, seawater drownings can make you hypernatremic, things like that. Also, if you need a little way to help you remember this, I don't like these things. I'd rather understand it, but I know a lot of students like these. You can remember FRIED, right? FRIED, fever, restlessness, increased fluid retention, and increased blood pressure, edema, and decreased urinary output may be ways for you to recognize that somebody is hypernatremic. Or SALT, skin flushed, agitation, low-grade fever, thirst. All right. They're a little low-grade fever because they don't have enough water to cool them, right? Just like marine engines on sailboats. Your body is kind of water-cooled, right? It's a water-cooled engine. All right. Now, there's hyponatremia. All right. And this is where the sodium level is low, less than 135. Again, important for you to know. So there's a red check mark. These are the potential causes: GI suction, diarrhea, inadequate salt intake. So if somebody is not getting enough nutrition at home, that could do it. We could see it with certain diuretics like mannitol or other loop diuretics, things like that, vomiting. So keep these things in mind as potential causes of hyponatremia. All right. It's hard to learn these, but every time you're exposed to them in a new course, and I know you were exposed to them a year ago in the technologies course. I know you were exposed to them last semester in pathophysiology. You're going to keep learning about them as you go through. So every time, hopefully, you'll remember just a little bit more. Okay. Now, you have to be very careful. And I'm just joking. I named this Logan's Law. Remember we talked the other day that the absolute value of the electrolyte level is less important than the speed with which you correct it. So for instance, if you get rapid onset of acute hyponatremia, that means you suddenly lose a whole bunch of sodium from working out, over exercising or something like that, you can get cerebral edema, right? Because you have a lower, your blood is hypotonic then, and you're going to have, yes, that's right. Then you're going to have more edema in the brain and potentially an uncal herniation, which means you die. It's bad. If you have rapid acute hypernatremia, like we give you an injection of, say your sodium's 110, and we give you sodium hypertonic saline over, a 2-hour period to get you up to 135, that can cause this demyelination syndrome where the myelin sheath dissolves around the neurons, and then you're brain damaged forever. So we don't care as much about the value, 120 sodium, for instance. We don't care as much about that as how quickly or how slowly we change the value. Okay. Now we have hypokalemia. Now, a lot of you are going to learn this and maybe already have, and I want to just help you focus a little more clearly. All nursing students learn that potassium affects or can cause dysrhythmias. That's true. But the dysrhythmias are very different with hypo and hyperkalemia. Hypokalemia causes ventricular tachycardia, ventricular fibrillation, the bad ones, right? So I want you to know that arrhythmias like tachycardia, like ventricular tachycardia, are typically seen with low potassium levels. Extra PVCs you see with low potassium levels. Okay. This can happen because people are taking in less potassium or they're losing too much potassium through things like nausea, vomiting, decreased intestinal motility or ileus, things like that. There can be hypokalemia that results from moving the potassium from the blood into the cells too quickly when the potassium in the blood is already low. So for instance, think of this. Somebody comes into the emergency room. They have a potassium level of 2.8, very low. And then we give them insulin, right? What's going to happen to that potassium? Well, it's going to go even lower because insulin helps facilitate passage of potassium inside the cell. So we have to be very careful. That's the reason they took calcium off of the code cart 20 years ago, was because they didn't want people's potassium level to go too low. And there are 4 things that can lower the potassium. We're going to talk about them in just a moment. Okay. So if we were in class, I would ask you to think about, how do we safely administer potassium? Remember, we can't give IV push potassium. Bad idea. So IV, we give 10 to 20 milliequivalents per hour, or we can give like 20 or 40 of PO potassium. What happens when you take PO potassium? It can make you nauseated. So we usually give it with food. So they don't throw up on us. Anytime you think about hyperkalemia, I want you to think about the kidney. And that's why the kidney is flashing at you right now, right? Now, we said that hyperkalemia and hypokalemia can both cause dysrhythmias, but the kind of dysrhythmia that happens with hyperkalemia is just bradycardia. And the way I think about it is this. There's so much potassium in the blood when you're hyperkalemic that it's extra hard to move it, right? So you're moving all this potassium and it takes longer. If your house is packed full of furniture when you move, it's going to take them longer to move it onto a moving truck. If you just have an apartment, like when you move from college, you're going to have like 4 boxes, 2 sets of books, and a wardrobe, right? Done. Easy to move because you have normal potassium level, theoretically. So when the potassium level is high, it takes longer to move all this stuff. And the way we see that is the P wave gets flatter and lengthens the PR interval. The QRS gets wider. We get a peaked T wave, which is not well represented here. I'll show you a better picture of it later. And it just gets really wide. The heart slows and eventually it just stops. Turns into a sine wave, right? That kind of looks like this. And so that's the dysrhythmia that happens with hyperkalemia. Very, very different kind of thing. So how do we treat it? Well, if we need to do it this instant, then we give them some medicines that will, well, I think I have another slide to talk about that. How do we get hyperkalemia? Well, if you're acidotic, you get hyperkalemic. If you have a crush injury where all the cells get crushed, why would that make you hyperkalemic? Well, remember, that's where potassium lives, right? In the cells. So if you crush a whole bunch of cells, like your leg gets crushed, your potassium level could go really high because all those cells got crushed and broken open, and now the potassium leaks out into the bloodstream. So there's different treatments that we can use. We'll talk about them in just a second. These are the symptoms. All right, so here's a better illustration of what EKG changes happen with potassium. This is normal. Sometimes, normally, you see a U wave. I saw a guy the other day with a U wave, which was cool to see because you don't always see it. But when you have hypokalemia, you may have a really high, prominent U wave, and it may look like the T wave is really high because it kind of mixes in with the T wave. This is the T wave here, but the U wave is actually bigger. So prominent U waves, slightly prolonged PR interval, maybe a peaked P wave. Hyperkalemia is easier to recognize. You see a widened QRS. Remember, it takes longer to move all that potassium around, so the length of time on the EKG is this way, right? This is time on the x-axis. So the QRS will widen, and then you get these tall peaked P wave or T waves, and that goes along with hyperkalemia. Okay? So how do we treat it? Well, we have to decide, is it urgent or do we have time? If the patient is symptomatic, they're getting hypotensive and bradycardic, and the QRS is really wide and it looks ugly, then we need to get it treated right away. And the way we do it is to force the potassium, the excess potassium, into the cells temporarily. So we can use sodium bicarb, insulin, but we always give dextrose too, right? Don't want to give them insulin shock as well. Then we could give calcium, and we can give inhaled albuterol, which is the rescue inhaler that people use when they have asthma or COPD. Now, if their potassium level is high, but we still have time, they're not symptomatic, their EKG is fine, they're fat, dumb, and happy, then we have time, we can start sodium polystyrene sulfonate, also known as K-exolate, which sometimes works. It smells delicious. I love the smell of it. Patients will not enjoy drinking it, so often it's given by NG tube, or you can give it rectally. And what that does is it sucks in the potassium from the bloodstream into the K-exolate that's in the gut. And so then you just poop it out. That's pretty easy. Loop diuretics are also famous for getting rid of potassium. So that's another way that we can get the potassium out of the body. And then if their potassium's high because their kidneys have failed, or it's high because of some other reason like crush injury or something, and it's just going to stay high for a while, then we can use dialysis or CRRT, continuous renal replacement therapy in the ICU. And of course, we would want patients who chronically have high potassium to be on a low potassium diet. These are some foods that you'll see that are high in potassium. Notice it's fresh vegetables, salmon. All the things that I despise are on this list. Lima beans, kale, avocado, spinach. I do like salmon. Bananas, mushy and disgusting. Mushrooms, that's a fungus. Broccoli, I can eat it if I have to, but I usually just put it on my plate for decoration. Beets, absolutely disgusting. Can't even stand the smell. Cantaloupe, what a waste of fruit salad. Tomatoes, all right, if you put it in a pizza sauce recipe, that'll be good. I do like sweet potatoes. But notice that these vegetable kind of things, very high in potassium. So people who need to have a low potassium diet, we want to tell them to avoid these kind of foods, right? But people who have high blood pressure and should be on the DASH diet because we want to raise their potassium and help them control their blood pressure, these are foods we should encourage, right? So know how potassium affects or what foods have lots of potassium, and apply that knowledge correctly, right? Whether we need to decrease somebody's potassium intake or increase it, this is a good starting point. Next is hypomagnesemia. This causes a particular kind of dysrhythmia, and this is called, anybody know? It's the twisting of the points, but we have a fancy French word for it, and that is torsade de pointes, something like that. I don't know. If you took French, you could probably say it better than I do, but the rest of the world just calls it torsades, right? So when you have torsades or twisting of the points, that is very often due to hypomagnesemia or other things that we'll get to later. But the treatment for it is always magnesium. We give magnesium. All right. So you can get hypomagnesemia from something like alcoholism, because the people who have alcohol use disorder tend not to eat very much. It decreases their appetite for everything except alcohol. It leads to malnutrition. If we have prolonged unsupplemented IV therapy, chronic diarrhea, pancreatitis, those kind of things. Elevated plasma free fatty acid levels can cause hypomagnesemia. And then if we excrete too much of it, like happens in DKA or hyperaldosteronism, those kind of things we would need to give magnesium for as well. Okay? Gastric suction, a lot of emesis or vomiting, and then certain drugs as well, like diuretics famously. Hypercalcemia, this is one of those things that's complicated. That means I don't understand it very well either. But hypercalcemia, the way to remember those problems are bones, stones, groans, and moans. So it can cause painful bones, right? It can cause this classic condition of inflamed bone tissue. It can cause kidney stones that can lead to kidney failure. It causes GI symptoms like nausea, vomiting, a lot of constipation, just belly pain all over. And it can also affect the brain. So it can cause lethargy, fatigue. It can even cause psychosis. So those are the things to remember for hypercalcemia. Again, I'm not super worried about it, but if you remember bones, stones, groans, and moans for hypercalcemia, that's pretty safe. I think that would be a good thing for you to know. And you can always look it up later, right? All right, now we're going to talk about diuretics. And my favorite expression, you'll pick these things up along the way, to pee is to live. What do I mean by that? Well, if you're making enough cardiac output that it gets to the kidneys and the kidneys are making urine, then you're living, right? You're alive. That's the main thing that we're looking for. If somebody is sleeping and can't respond to you, but you want to know if they have a good cardiac output, the easy way to figure that out is to see if they're making quantity sufficient urine, which for adults is, remember, about 30 cc's per hour, right? Now, let me just refresh your memory about the nephron. It's kind of a complicated mess, but it starts with the afferent arteriole that takes arterial blood to the nephron. To the glomerulus, which is part of the nephron. And in the glomerulus, this arteriole sends fluid into Bowman's capsule, right? And then that bloodstream, after it's emptied itself of mostly, it's essentially just dumping plasma minus the proteins. It's essentially just dumping plasma into the Bowman's capsule and then taking what's left, the big proteins and the blood cells, into the efferent arteriole that goes then and wraps around the proximal convoluted tubule, right? That comes from Bowman's capsule, goes to the proximal convoluted tubule. And that's served by the efferent arteriole. And then it goes down to the loop of Henle, where it's still supplied or serviced by the efferent arteriole. And then the distal convoluted tubule, after it goes through the loop of Henle. And there's all sorts of different things that happen here. That's the exchange of what's in the collecting urine, or the nephron and in the bloodstream. It transfers things like glucose and sodium and moves them across that membrane. And then finally, the urine ends up in the collecting tubule. Okay, so again, the blood flow is afferent arteriole to the glomerulus, dumps out essentially the plasma minus the big proteins, and then the blood flow goes to the efferent arteriole, where it wraps around the proximal convoluted tubule, goes down the loop of Henle, and then comes back up to the distal convoluted tubule, And then that blood flow goes back to I don't even know what it's called. I don't know what that is. It's just a vein, right? It's probably has a name. And then the urine gets dumped into the collecting duct. And there's still some work that gets done here. Now, this is good for you to know because this tells you at what part all of these things have their function. So again, the afferent arteriole, it's upside down this time. Sorry about that. But the afferent arteriole comes in, delivers the plasma into Bowman's capsule at the glomerulus, and then the blood goes back into the efferent arteriole where it goes around the proximal tubule and the distal tubule, right? In the proximal tubule is where osmotic diuretics and carbonic anhydrase inhibitors work. That's two of the types of diuretics that we have. The loop diuretics work in the distal or ascending loop of Henle. All right, that's where the loop diuretics do their thing. There's some action from the osmotic diuretics in the descending loop. And then thiazide diuretics and potassium-sparing diuretics do their work in the distal convoluted tubule and the collecting duct. Okay? So it's good for you to know where these things do their work. And I'm really only interested in you knowing where the loop diuretics, thiazide diuretics, and potassium-sparing diuretics work. All right? Loop diuretics are easy because they work in the loop of Henle. Now, thiazide and potassium sparing, they work in the distal tubule. So as far as potency goes, the most potent of those 5 diuretic classes are the loop diuretics. Second is the osmotic diuretics like mannitol. We use those in the neuro ICU quite a bit for brain edema. Thiazide diuretics, which is what most of your parents are taking to keep their blood pressure controlled. And then we have the carbonic anhydrase inhibitors. We'll talk about their special effects later. And as far as potency goes, the amount of fluid that they put out, the potassium-sparing diuretics are the lowest. All right, they have the least amount of effect, and they really don't produce very much urine at all. But they act in the nephron. That's why we call them diuretics. So the loop diuretics include the ides, furosemide, bumetanide, torsemide, and ethacrynic acid. So which one of these is not like the other? Well, ethacrynic acid. The thing about this is, and you'll never give ethacrynic acid. I think I've given it twice in my entire career. But the reason that we have it is because these 3 medicines, any of the ides, have a sulfa group. And although most everybody who has a sulfa allergy can take a loop diuretic without a problem, there are some who have an allergy that doesn't allow us to give the loop diuretic. In that case, if they need a loop diuretic, then they need ethacrynic acid or etacrin. All right? But just know furosemide, that's the one that I want you to memorize. Bumex is nice because it's better absorbed in the gut. Torsemide is nice because it gives you a longer duration of action, which makes you have a nice gentle diuresis instead of Lasix, which you hit people with and it lasts 6 hours. Get it? Lasix lasts 6 hours about. So that's how that works. Loop diuretics are the most potent, remember. They work even when the kidney function is terrible. And that's a wonderful thing because we find patients with terrible kidney function all the time. And we need to be able to get fluid off of them. And therefore, we like loop diuretics. Okay? They work in the ascending loop of Henle, right here at number 3. Lasix can be dosed from, I've seen it at 10 milligrams, which is just a tiny bit, up through 120 or even higher doses. Or we can put you on an IV drip if we just want to really hit you with a ton of Lasix. We use it when there's too much fluid on board. Pulmonary edema, CHF, those kind of things. It has an onset orally of about 30 to 60 minutes, and it lasts for, 6 hours or so. All right. Adverse effects. Notice hypokalemia, low potassium. It wastes potassium through the kidneys. Hyperglycemia. Whenever we use a diuretic, any of the diuretics can increase the glucose level. Can cause dizziness, hypotension. That makes sense if we dry somebody out, right? It can also cause hyperuricemia, which is high uric acid levels that may result in gout. So those are potential downsides. The beauty of Lasix is it's cheap, but you have to remember that it does have a sulfa group and there could possibly be an allergy. So here's the way I deal with it. If they've been on a diuretic in the past, if they've been on a loop diuretic and they've tolerated it, I don't even bring it to the provider's attention. Because they've been on it, we know that they're not going to have a new allergic reaction to it. I mean, most, 99.999 times, it's fine. If they're already taking it, don't bother bringing it to anyone's attention. Okay? Osmotic diuretics work in the proximal tubule, right? And we use these to treat brain injuries a lot. When we need to get rid of certain toxic substances, then we use them as well. We don't use them other than very specific indications like that. All right. And whenever we give it, it has to be administered with filtered IV tubing because there can be little tiny microscopic chunks of mannitol in the solution. Thiazide diuretics, again, work on the distal convoluted tubule, and they inhibit the reabsorption of sodium, potassium, and chloride. Why is that important? Well, because, remember this, with sodium goes water, right? So when we inhibit, and reabsorption refers to the bloodstream. When we inhibit the reabsorption of sodium, keeping sodium from coming back into the bloodstream, then it goes out in the urine, and along with it goes water. That's how it works, right? We relax these small blood vessels or the peripheral vascular resistance, and that's why it's good for blood pressure. So although it seems that the amount of, or that the thiazide diuretics work to lower the blood pressure by getting rid of volume, that's not really true. You only pee extra for the first day or two. And then it works mostly through the sodium channels in relaxing the small blood vessels to reduce peripheral vascular resistance. All right. It's hard to envision that, but it's important to know because you don't really get rid of a lot of fluid with thiazide diuretics like hydrochlorothiazide until you get up to like 100 or 200 milligrams of the dose. But when we use it for hypertension, we're using like 12.5 milligrams or 25 milligrams, maybe 50 milligrams. So tiny, tiny doses that don't really get rid of a lot of extra fluid, but that lower the blood pressure because of the reduction in the peripheral vascular resistance. Okay? Now, unlike the loop diuretics that we can use no matter what what the kidney function is like, as long as they're still making urine, we can use loop diuretics. Thiazide diuretics are different. We can't really use them if they get down to CKD stage 4, which is 15 to 30 milliliters per minute. So thiazide diuretics have a limit that we can use them. They have to have adequate kidney function, and they don't really work by getting rid of fluids, but rather by peripheral vascular resistance. Hydrochlorothiazide or hydrodiuryl is the old brand name. Nobody calls it that anymore. You'll probably see it referred to as HCTZ. That's how we refer to it now. We use it for hypertension. In ladies, we really like this because it helps keep their ankles skinny, and older ladies like to have skinny ankles, right? So it works in both ways, both for cosmetic effect and for blood pressure effect. The duration of action is somewhere around 6 to 12 hours, and adverse effects include, blood pressure that's too low. Again, gout from hyperuricemia can happen. It can make the potassium level too low. It can make the glucose level too high. Pretty much the same exact things that can happen with loop diuretics, right? What else did I want to say? Oh, so 90% of the time when I start somebody on one of these drugs, like hydrochlorothiazide, their lab tests are just fine. I always check a metabolic panel in 1 to 3 or 4 weeks to make sure, and I rarely see a problem. But 10%, maybe 5% of the time, somebody's blood sugar gets too high, or their potassium level plummets, or their sodium level goes to 120 or something like that. So you do have to do that quick check of the chemistry panel. Nice thing about it is that it's cheap, and we usually tell people to take it in the morning so they're not up all night peeing extra. Next is the potassium-sparing diuretics, and these act in the collecting ducts and the distal convoluted tubule, right? So these are number 5. They act right here. And what that does is it prevents sodium-potassium exchange. So they're very weak diuretics, but they work nicely with thiazide diuretics. So if you have somebody who is on hydrochlorothiazide and their potassium levels, 3.2, 3.5, and you want to get better blood pressure control, we can add a potassium-sparing diuretic that will both treat their blood pressure better and make it hold on to more potassium. Okay? Now, I would prefer that you not think of these as potassium-sparing diuretics, but rather 2 of them, spironolactone in particular, and its cousin, eplerenone. Spironolactone is an aldosterone blocker. And if you remember physiology, aldosterone makes the kidney hold on to more water, right? More sodium and water. So when we block aldosterone, we have an even better effect than we have without blocking it, right? So we love aldosterone blockers like spironolactone in heart failure. They reduce hospitalizations. They make people live longer. They are wonderful. But it's not true of all the potassium-sparing diuretics, right? The way I explain this to students is that spironolactone we classify as an anti-aldosterone agent that just so happens to have potassium-sparing capabilities, and that's usually not a good thing in heart failure. In heart failure, we often see the potassium level too high, and then we can't use this drug class. All right? So, spironolactone or aldactone, at low doses like 25 milligrams that we use for heart failure, even up to 50 milligrams, we typically don't have the most common side effect, which is gynecomastia. Of course, hyperkalemia is the most feared one, right? But gynecomastia is breast tissue formation that happens in men. Again, usually at higher doses. We don't often see it at the 25 milligram dose, but I have seen it and had to switch. That's why we use eplerenone sometimes. This stuff is fairly cheap, though, and easy to use, and we love it. It gives great blood pressure control. It makes the kidney hold on to potassium, which can be good or bad. It makes you live longer if you have heart failure. I mean, we absolutely love this drug. Love it. And we want to use it a lot more. We can't use it in chronic kidney disease. Why not? Because what goes along with kidney disease, when the kidneys are failing, the potassium level goes up, right? And so we may end up having hyperkalemia, right? And then we just have to caution men about the use of spironolactone and maybe causing gynecomastia. And of course, it's pregnancy category D because it actually has the reason that it causes gynecomastia and is pregnancy category D is because it's actually an analog of estrogen. And that's all I can explain. I don't know the rest of it. So what are the nursing implications for diuretics? Well, we're going to always perform a thorough history and physical. We want to assess their baseline fluid volume, their intake and output, their lytes, right, their electrolytes. And we're going to weigh patients every day and check their vital signs, especially orthostatic vital signs. If they come in, they have dizziness or lightheadedness, or they came in with a fall and they've been on diuretic, then we definitely want to check their orthostatics. We're going to look for any things that may make a contraindication to the use of diuretics. And we're going to instruct the patients usually to take their diuretic in the morning so that it doesn't interfere with their sleep pattern. I did have one patient once who said, I take my Lasix at night. And he took it, I think, twice a day. I think he had 2 doses of Lasix. And I said, why in the world would you do that? I mean, you're up all night peeing. He said, because I'm busy during the day. I got stuff to do. It's hilarious. He was such an active guy that he didn't want to be going to the bathroom all the time during the day. And he said, you know what? If it's just going to the bathroom, I do that all night anyway, so I'll just take my diuretic at night. Thought that was pretty funny. We're going to aggressively monitor serum potassium levels while patients are on any of these diuretics, whether it's a potassium-sparing diuretic and we're looking for too high of a potassium, or if they're on a loop diuretic or thiazide diuretic and we're worried about the potassium level going too low. We want to teach patients about their proper nutritional and fluid volume status. And so for patients who have heart failure, we like for them to take their take their weight daily. Get on a scale the same time of the day in the same condition. Usually it's first thing after you empty your bladder in the morning, and you get on the scale. If you gain 2 pounds overnight or 5 pounds over the course of a week, you should contact your provider, or maybe they've given you instructions to just take an extra dose of diuretic. But that's the way that we do it. 2 pounds overnight or 5 pounds over the course of a week. You've probably heard that already. I skipped to the end of there. Sorry. I got excited. And then we're going to teach patients to change positions slowly. Now, when you're 20 years old, you can go from being sound asleep to running in 3 seconds and not have any effect. But as you get older, your nervous system doesn't equilibrate as quickly. And so as people get older, already they're at a disadvantage for their blood pressure to drop. And then you add to that these medicines that we have them on that are poisoning their circulatory system, poisoning in a good way, right? But affecting their ability to change their blood pressure quickly. So have patients sit on the edge of the bed for 2 full minutes before they get up. Always sit on the edge of the bed for 2 full minutes before they get up. And if they're laying on the couch, same thing, right? Change position slowly and be on the lookout for low blood pressures. We have to be careful when patients are taking diuretics with certain medicines like digoxin or lithium or things like that. We'll talk about those later as well. People who are diabetic, remember that it may cause higher blood sugars. Now that's usually a very, very low effect. I mean, it may raise your blood sugars, 5 points, maybe. And it's usually okay. We're usually getting more bang from lowering the blood pressure than we are worried about the very slight increase in the glucose level. All right. And then if people are ill, nausea, vomiting, diarrhea, things like that, we may just back off on their diuretic for a time until they get better. Last thing, real quick, I want to talk about anemia drugs. Just remember that erythropoietin, I'm just going to keep this very simple, right? Erythropoietin is the thing that stimulates erythropoiesis, right? And so the stem cell makes the stem cell in the bone marrow makes all of these precursors to red blood cells. Eventually we get to the reticulocyte, which is the very beginning, and it still has organelles in it, right? Before it finally matures into a red blood cell. Red blood cells circulate in the blood for about 120 days or so. And that's how it's made. Epogen, or erythropoietin, stimulates that process. And as the kidneys start to fail, erythropoietin doesn't work anymore. The body doesn't make the erythropoietin anymore. And so we oftentimes, as people have worse and worse renal function, they often become more and more anemic, and we need to give them epogen or erythropoietin. So we use it for anemia caused by chronic renal failure. It's a biosynthetic version of erythropoietin. But remember, it does not make the blood. It just stimulates the blood to be made. And what I mean by that is you still need all the building blocks. So what are the building blocks of red blood cells? Well, you need the iron, right? And we get most of the iron from old dead red blood cells. Now, if you're bleeding somewhere, like you have colon cancer and you're bleeding into your bowel, you're losing more iron than you can keep. But the vast majority of iron that is used to build red blood cells is recycled from old dead blood cells. Okay? You also need folate or folic acid, and you need B12. So all those things need to be present in order for erythropoietin to be able to work. Okay? We inject it 3 times a week, and then we monitor their hemoglobin. And if their hemoglobin's normal for a week, then they skip the erythropoietin until it starts to go down again. So again, iron deficiency anemia, is where the iron is being lost, or you're not taking in enough. Now, only a small fraction, I always forget the numbers, but it's something like 10 or 20% at the most of the iron that is used to make new red blood cells comes from your dietary intake of iron. I think you need 20 milligrams a day, and only 1 milligram per day can be absorbed. I think those are the numbers. It's something like that anyway. So that's why iron deficiency anemia is so bad. If you don't have enough iron, then we need to give you iron. So we give dietary iron and B12 and folate if needed. Cyanocobalamin, or B12, is used by the body, by the bone marrow, to make the red blood cell the right shape. Okay? It's essentially a structural component. It's like the foundation. Same thing with folate or folic acid. They don't lower your blood count. They just change the shape of the red blood cells if you don't have enough. So we give B12 and folate. When we give iron, we can give ferrous sulfate, which tends to make people constipated. And then people say, oh, we'll just give them ferrous gluconate. It's less constipating. Well, why is it less constipating? It looks like it's the same dose, right? But the amount of elemental iron is much lower. That's why it doesn't constipate you as much. Ferrous sulfate has 65 milligrams of elemental iron, and ferrous gluconate has 39 milligrams of elemental iron. So there's much less iron in ferrous gluconate. So when we give oral iron, remember you need an acidic environment for it to be taken up in. Remember that it can cause dark stools, right? So it may mimic chronic GI blood loss by itself. So make sure you ask the patient if you see black stools, do you take iron? And they'll say yes. And then you'll know that we don't really know if it's blood or not. You'll have to heme test it. And then we have IV iron. The problem with IV iron is that it's very likely that they'll have I shouldn't say it that way. The chance of anaphylaxis is higher with IV iron. It can also lead to hypotension, cramps, nausea, vomiting, and things like that. But we do give it, and it looks like purple ink, like really dark indigo colored ink. And when we give it, it goes over 15 minutes or so and is mixed. Well, it usually comes up from the pharmacy already mixed. Maybe you've given it already. So that's